Our focus tonight is America's obesity epidemic. There's a growing body of scientific research that could potentially help everybody seeking to lose weight, as well as many people dealing with diabetes. Our guest this week is Dr. Ava Port, Assistant Professor of Medicine at the University of Maryland School of Medicine and an endocrinologist at the University of Maryland Medical Center. So glad you're here. Thank you for being with us.
Thank you so much for having me.
Tell me about your practice. What do you do?
I'm an endocrinologist by training, so I primarily see patients with hormone or gland problems. So that's like diabetes, thyroid dysfunction, and then a big portion of my practice is also dedicated to treating people with obesity.
How often does obesity overlap with an underlying issue like diabetes?
Quite frequently, actually. About 85% of people with type 2 diabetes are in fact overweight or obese. A large portion of patients with thyroid dysfunction at some point struggle with weight issues, and sometimes weight gain is actually a consequence of a variety of endocrine or metabolic problems, so quite a bit actually.
What do you counsel people about weight loss? You see some people who need to lose a little weight, I guess, and some people who need to lose a lot of weight.
Yeah, so it really depends on the individual. First and foremost, I try to address specific needs to that patient, try to learn a little bit more about their weight history, their medical history, medications that might be contributing to that individual person's needs. And then as far as general counseling for diet and exercise habits, there's things I try to apply to everybody. First and foremost, certainly eliminating things like sugar-sweetened beverages, juice, soda, beverages that have excessive amounts of sugar added to them that we may not even think about. That's a big source of extra calories in the diet for a lot of people. Things like being consistent, trying to go after high protein snacks, watching portion sizes, and working regular exercise into the daily routine.
How much is it a simple matter of how many calories I'm putting in versus how many I'm expending?
So it's not exactly a perfect equation. Certainly, obesity is a consequence of an energy imbalance, meaning taking in too many calories out of proportion to what the body needs. But it's the what the body needs part of the equation that I think becomes a little bit more complicated. We're not always able to measure on a day-to-day basis how much our body needs, and most people's bodies should be able to regulate weight within, say, about 5 pounds. When you look at people over the course of a lifetime, most individuals are able to maintain their weight, usually as young adults, within a certain frame. It's going outside of that kind of set point where your body likes to sit. That's a consequence of taking in too much energy, and that's when we start to see weight gain.
So there's sort of a self-regulatory system like with other things. I mean, certainly if blood sugar is working properly, you have insulin and it keeps a balance. Are you saying that the body is designed, if everything's working right, to sort of keep the weight in a set range?
Yeah, so there's actually quite a complicated and really beautiful system that's evolved over time to regulate appetite, regulate weight. Our brain really likes to keep tabs on energy going in and out of the body. If energy's a little bit down, it'll drive appetite. If we've taken in a little bit too much, it might fine-tune our metabolism in the days to come. Maybe, adjust the way that we expend energy. And it really likes to keep the body within a certain weight for your frame. That's your ideal body weight. And when that system breaks down, it's usually a consequence of chronic disease. Something's happened with that adaptive mechanism where your body's no longer able to keep all those signals that fine-tune your weight in check.
I had thought that we had evolved to eat whatever was there. Because certainly in prehistoric times, food was scarce, and if it was there, you were going to feast and save up energy in the form of fat for periods where there may not have been as much food around. Consequently, my working theory was when there was ice cream in the fridge, that's why I couldn't avoid eating it. But you're saying that's not really the main driver here. This kind of prehistoric urge to just consume whatever calories were around.
No, just to clarify your point, that's not what I'm saying. What I'm saying is that is true. There is some sort of evolutionary mechanism to store energy. Absolutely. We're all driven to consume sugar, fat, salt, when it's abundant in our environment. Those are all the things that like you mentioned, our prehistoric ancestors were always in search of.
But at some point, the body would say, "All right, that's enough."
Exactly.
Yeah.
And we never really have that famine time that our ancestors were struggling with. So our evolutionary programming to store energy is still there. We're in fact quite efficient because our ancestors survived. The ones that were able to pack on energy and store so that for times in famine they had energy stores in their body available, those are the ones that survived to reproduce. Those are our ancestors. But now in this modern environment where we have food abundance, that system where ultimately, our bodies should be able to regulate weight, there's something about the modern environment where our body and brain really can't keep up with that. Whether it's chemicals in the environment, whether it's the food quality, the types of food, the sedentary lifestyles that most of us lead, many of them interacting. Who knows which one or all of them specifically? But there's something where, as a group, we're no longer really able to keep our weight in a normal, healthy range. Over a third of the population is actually obese. About 2/3 are overweight. And this isn't something that our ancestors were struggling with.
I see a lot of products in the grocery store now that say no high fructose corn syrup. Mm-hmm. And as a layman, I think if they're substituting a bushel of sugar instead of, what difference does it make? Is there anything to it?
Yeah, so there is a little bit to it. High fructose corn syrup is something that emerged after the 1960s and inched its way into the food supply and has been increasing rapidly since the 1970s. And, fructose is metabolized in a slightly different way than its other partner, glucose. But when you talk about sugar being metabolized by the body, so sucrose, which is common table sugar, that white stuff you might add to your coffee, sucrose is actually
go on.
Exactly. So it's half fructose and half glucose. There's plenty of fructose in the human food supply that was there, independent of high fructose corn syrup. High fructose corn syrup is actually about 55% fructose and then about 45% other sugars. It can be a little bit higher than that. But it's used in abundance because it's got a longer shelf life. It tastes sweeter than other forms of sugar. And so we tend to like it. We tend to gravitate towards it. Fructose is metabolized in a little bit of a different way, though, than glucose. And it tends not to register the same way in our brain. Our brain doesn't feel those sugar calories. It doesn't fill us up in the same way.
Let me remind our viewers, if you have a question about weight loss, whether in the setting of obesity or otherwise, please give us a call. We'll have the number on the screen. You can also tweet a question to us. Use the Twitter address @MPT News. So you talk about sugar and the brain. Are we addicted to it? I mean, do we get that sort of signaling the receptors in the brain that are activated in people maybe the way drugs do?
Yeah, so certainly different nutrients hit the brain in different ways, and certainly we are programmed to crave and desire sugar. Sugar is the main fuel of the body, and certainly fructose actually registers in a different way than glucose does, the other component of sugar we were talking about. They've done studies where they look at brain pictures after people take drinks containing one type of sugar versus the other, and they do actually light up different parts of the reward pathway in different ways. So, I think in small quantities, sugar is certainly safe, not harmful to the body. It's in excess quantities. When we take in too much sugar, certainly too much refined sugar like fructose, that's where we may start to see health consequences from it.
Let's take a phone call. This is Ann in Fairfax County. Ann, thank you for calling. Go ahead.
Sure. Hello. I think you started to talk about this, but I wondered if you would talk about insulin resistance. I have a relative who's a lipid specialist, and, he's very focused on cholesterol and LDL cholesterol and so forth, and how important it is, in his view, to cut down on carbohydrates. And in a way, you've been talking about that.
No, that's great.
But, Okay.
Thank you very much for the call.
Sure.
Yeah. Absolutely. So certainly when we talk about taking in too much energy or when we talk about eating a meal, our body can only process so much of the food that we take in every given meal, and excess amounts of sugar will actually get turned into fat by our liver for burning, for storing. And so certainly a diet that's full in extra sugar and processed sugar is going to lead to fat being made by your body, including the LDL or bad cholesterol that she had mentioned. So certainly limiting the amount of dietary sugar you take in is part of a healthy, balanced way to limit cholesterol.
This is Rose in Baltimore City. Rose, thank you for calling. Go ahead.
Yes, I wanted to ask, is there anything that you would recommend as far as eating to get rid of the weight as well as the diabetes?
Excellent question. Thank you very much.
Absolutely. So some of the things I really stress to my patients with diabetes are eliminating sugar-sweetened beverages like soda, juice, any kind of liquid sugars. And then in terms of diabetes, we really want to bulk up on things like protein and non-starchy vegetables. That would be like broccoli, leafy greens, potatoes. Fiber-rich vegetables actually help limit how quickly you digest your food, how quickly sugar rises as you digest your food, and protein helps keep us feel full and satisfied with our meals. So meals that are composed mostly of protein and non-starchy vegetables and limited in refined carbohydrates and starches like potatoes, breads, and grains are really helpful for people with diabetes to limit how much their blood sugar goes up after a meal.
Let's broaden out to everybody who wants to lose a few pounds.
Yep.
What diets, what types of programs have you seen succeed?
Yeah, so there's actually a broad range of programs that are acceptable to be used. When they've done meta-analyses, which are large studies where they put lots of information together to compare many studies, there's actually been no one type of diet that's emerged as the best diet. Low carbohydrate diets, high carbohydrate diets, low fat diets, Atkins, you name it. The diets that work and the diets that are most effective are the ones that people stick with. And across the board, all the research studies, when they look at that, it's how well you adhere to your diet or stick to your diet that leads to the most weight loss or most success.
Can you tell in an office setting when somebody embarks on a plan whether it's going to work, whether they're likely to stick with it?
Yeah, so that's where I try to get a good sense of how they eat and the types of foods they prefer beforehand. Obviously, recommending a high, lean protein diet to a vegetarian might not be the most appealing, or a shake-based diet to somebody with lactose intolerance. But absolutely, so I'll try to feel out patient-specific factors. And then if somebody doesn't really like counting, sometimes a meal replacement program with shakes and or portion meals where they don't really have to think about the foods works well for them. Sometimes just kind of portion control and having patients refine what they're already eating and just cut back on the total amount they're taking in. So there's a variety of ways to approach it, and it really depends on the individual.
Have you seen any good apps? Everything's about apps, you know? And there's some where you write down the calories and exercise, and then you forget to do it after a while.
Absolutely. So there's many apps available. One of my favorites is called MyFitnessPal. There's been over about 40 million downloads worldwide. It's free, it's easy to use, and you can track both calories, foods, and exercise habits. So I really like that one. I'm not endorsing it in any sort of way.
No, that's fine. And I wonder how many of the 40 million, used it for more than a week.
Who knows? But I do find that my patients who are tracking their intake do find it easy to use apps like MyFitnessPal or Calorie Counter or Lose It. There's many out there. I encourage people to play around, especially with the apps that are free, to download multiple apps and try them all out to see which one they prefer using.
Let's talk to Tim in Charles County. Tim, thanks for the call. Go ahead.
Hi. I'd like to ask if you are conversant with late adult onset type 1 diabetes. It's also called type 1.5 or LADA.
Sure.
What's the question, Tim?
I find very little information available about it. it's just something that there's just not much there on.
So I think Tim's asking about a disease that's really specific. It's a form of diabetes type 1, which is an autoimmune or insulin deficient diabetes that starts in adulthood, not typically associated with weight gain. If you have further questions, I certainly encourage you to seek out an endocrinologist, like the ones that we have at our program at Maryland, and we could answer more specific questions for you.
People may have noticed that you have a blob of something sitting to your left on the desk here. What did you bring along?
So I brought 2 models of fat over here. This is a 1 pound example of muscle.
This looks very nice.
This is a 1 pound example of fat.
Looks like a blob of fat.
And it's nice and gelatinous. This is nice and firm. And I think this is a nice visual display, really, so people can understand, so patients can understand that muscle and fat do not weigh the same pound for pound. Because I think a lot of people get frustrated, and patients of mine get frustrated when they don't see the number on the scale moving, but yet they start seeing they have to tighten up a notch on their belt, clothes are fitting a little bit differently, and they're really struggling with the number on the scale.
So this is really interesting. So is the goal to turn what's in your right hand into what's in your left hand, or to get rid of the thing in your right hand?
A little bit of both. So as far as weight loss and weight maintenance, it becomes really important to replace some of the fat tissue that you're losing with lean muscle. That's where making sure you're taking in good amounts of protein becomes important, and getting regular exercise. Typically about 150 minutes per week or more, about 30 minutes 5 times a week. So building lean mass or muscle is actually critical because it's more metabolically active than this stuff over here. So it helps keep your metabolism up. Muscle mass per se doesn't really replace the fat. What it's doing is it's help your body burn more energy all in all. And help keeping you from regaining some of this stuff over here, this fat tissue.
Great point. Next up, Bill in Harford County. Bill, thanks for calling.
I get a little confused about sugar consumption because we read a lot about eating fruits and that kind of thing. And aren't fruits pretty heavy in sugar?
Yeah, thanks for the phone call. And you mentioned, and I didn't jump on it at the time, that fruit juice was on your list of things to cut back on.
Yeah, absolutely. So this is something that definitely comes up a lot with my diabetic patients. Fruit is absolutely full of sugar, both types of sugar, glucose and fructose. The one nice thing about fruit, eating it as a whole piece of fruit, is there's actually quite a bit of fiber in fruit, which you don't find in fruit juice. And so when you think about eating a whole piece of fruit, there's quite a bit your body has to do to digest that piece of fruit versus the juice form of fruit, where it's already in liquid form, very rapidly brings your blood sugar up. So if you're going to have fruit, definitely go with a whole piece of fruit rather than fruit juice. And I generally encourage my patients to limit it to about 3 servings or less per day.
Let's talk for a minute about the future of medical therapy here, the prospect that we get the silver bullet pill, and you can talk a little about what you have in the arsenal now.
Sure.
But I also wanted to ask about this research that I read about maybe a month or 2 ago about the bacteria in our guts, and apparently there's a difference between the bacteria in the intestines of a thin person versus a not thin person, and there was some experiment with mice. What was that?
Sure. So why don't we take a stab at the bacteria first?
Okay.
So yeah, some really interesting stuff that's emerging. It appears that there are some differences between the bacteria. And just to take a step back, the microbiome, or the bacteria that live inside of our guts and in our body and our skins, they're naturally occurring. They're supposed to be there. They don't cause disease. And in fact, the microbiome, or the set of bacteria that live inside of us, are more numerous than the amount of human cells we have inside of us. They break down food. They provide nutrients for both themselves and for our bodies. And they're actually able to manufacture different substances for us that we don't even make, like vitamin K, for example, from our food. And how these bacteria interact with our gut, interact with our bodies, we're just beginning to understand. But you can imagine that if you have this entire gut filled with little organisms that are constantly breaking down nutrients and making things for us, some might be better than others. And in fact, when they look at humans, mice, different animals, there does seem to be difference between animals and humans which are lean and animals and humans which are obese. And like you mentioned, some of the interesting work in mice where they've shown transplanting the bacteria from the guts of lean mice helped make obese mice actually more lean. What we don't know, and there's still so many questions to be answered, is whether the bacteria that are associated with being lean are a consequence of being lean, and vice versa, the bacteria in the obese individuals that are associated with that.
Well, it's an interesting clue, though, that if you transplant it into the fat mouse.
Certainly. And it does seem to be more a marker of disease and a cause of the health rather than a consequence. But
all right, well, let's take a phone call. Then I'll get to the other part of the question. Sorry, I asked you like an 8-part question, but we'll talk about drugs in a second. This is Rupa in Wicomico County. Thank you for calling. Go ahead.
Hello. I'm calling to ask you if you could say if someone with diabetes or someone with insulin, when they build up abdominal obesity, if they exercise and lose the weight, can their diabetes be reversed?
Great question. Thank you so much.
Sure. And I get this question a lot from my patients. So someone requiring insulin on diabetes is a little bit more far advanced than somebody who doesn't require insulin, can manage their diabetes with diet or, say, with pill medications alone. But there's still a good chance that with a substantial amount of weight loss and diet modification that they might be able to get off of the insulin therapy. When most people are diagnosed with type 2 diabetes, they've often had pre-diabetes for about 5 to 7 years before the diagnosis was made. And at that point, the cells inside their pancreas, that's the organ that makes insulin for us, about 50% of them aren't working. And so what we don't know at any given point when we start treating someone is how many of those cells are left working, how much insulin-making cells are still there and able to recover. And so certainly weight loss and controlling blood sugars is in everyone's best interest and can help promote those cells to start working again. But it's possible someone's diabetes is far enough advanced that they've lost enough of those cells and they're not going to get function back to make insulin. So most people can recover that function with good weight loss and diet habits, but not everybody. So I try not to tell people in advance. Typically, though, making an attempt at weight loss gives you a good indication of how you're going to respond to therapy. So I encourage everybody to do it.
On to the drug question for a second. What do you have now and what's coming down the pike?
Sure. So there's sort of two varieties of medications that are approved. First, there's not many, I can tell you that. One is something called Orlistat or Allies, the over-the-counter version. That's a fat-blocking medication.
Right.
Unfortunately, when you block fat absorption up above,
some horrible side effects.
Yeah, it has to come out from below. So a lot of times that causes a lot of gastrointestinal symptoms that most people can't tolerate. And then the other group of medications we primarily use are appetite-suppressing medications. There is a group of stimulant appetite-suppressing medications derived from something called amphetamines. These have been around since the 60s, actually. There's been different versions of diet pills that have emerged. And then more recently, in the last 6 months, there's been approval of a medication called Belviq or lorcaserin. That works on a different pathway, actually, in a part of the brain to suppress appetite. And that's really it. So we have stimulant appetite suppressants, we have Belviq, and we have fat blocking, lipase inhibitors. And other than a few diabetes medications, which are only applicable to people with diabetes, which can affect appetite, there's really limited medications available in the United States for treatment of appetite.
Is there anything around the corner, anything you're hearing about?
There are a few medications that are undergoing phase 3 trials, and what that means is they're being tested by pharmaceutical companies, but they're not ready for approval or consideration by the FDA.
Very good. We're going to leave it there.
Sure.
Dr. Ava Port, University of Maryland endocrinologist, thank you for coming by.
Pleasure.
We appreciate it.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.